Hello, class. We're going to be talking about arrestin today for those of you who have to do the local drug delivery skill assessment. So here in this image, you can see this is the arrestin cartridge right here. And underneath this blue tip, when you remove this blue tip, you'll see like a yellow substance. And that's the arrestin, which is minocycline. That's located underneath this removable blue tip. And here is our autoclavable arrestin syringe. So arrestin is minocycline, which is in the family of tetracyclines, and it's actually composed of little microspheres, which are little small balls that are in a powder form within that plastic cartridge. When the powder comes in contact with the gingival crevicular fluid, subgingivally, it hydrolyzes, which means it turns the powder sort of into a sticky substance that will adhere to the surrounding surfaces. Um, and within that sticky substance that's created when the powder comes in contact with the GCF, there are little water-filled channels, very similar to the pores that we have in our phospholipid bilayer of our cell membranes. The same thing kind of happens here where water-filled channels are formed within that sticky substance, and that provides a sustained release of the minocycline over time. So Arrestin was approved by the FDA in 2001. It contains 2% minocycline in each unit dose cartridge, and each unit dose is 1 milligram. The drug itself is resorbable, which means that the body will degrade it over time and you will eliminate it from the body. So they don't have to come back to have it removed or have any kind of periodontal dressing. The body will resorb it. I think I misspelled this. Wait a minute. Resorbable? What's that? Resorbable. There we go. And it can remain active within the pocket for up to 14 days. It's not recommended for abscess pockets. It's not used to treat abscesses. It has not been studied in its effectiveness at treating abscesses. So the mean pocket depth changes is about 1.24 to 1.56 millimeters. Might be good for AA, and I'm being tricked here because I don't remember actinomyces. You guys know that one. So in a journal from 2007, it significantly improved pocket depths, cals, bleeding, and reduction of red complex in smokers with chronic perio. So let's look at how you kind of get that little plastic piece into the syringe. So you want to connect the cartridge, and this is the cartridge right here. The drug is right here, and it's covered with the blue tip. You have to pull back on this thumb ring, and then you twist the cartridge into place. You want to remove the tip cover and insert the cartridge to the base of the pocket. Now, in between that step, between removing the tip cover and inserting it to the base of the pocket, I take the blunt end of my mirror and I squish sort of the tip flat. I find if I squish that tip flat, it slides into the pocket a little easier. So then you slide it to the base of the pocket and sort of like relax your hand a little bit so that you kind of come out just the tiniest little bit so there'll be some space for the drug to be squirted into. So when you press down on the thumb ring to expel the powder, at the same time, you're also taking the tip from the base of the pocket. So you're releasing the drug from the base of the pocket all the way out. And then when you're done, you want to pull back on the thumb ring and you can pop the cartridge right out. So if we look here at these images, if you could imagine that if this tip was just a little flatter, if you flattened it, it might slide in there a little easier. The same thing here. So usually I will flatten it with the blunt end of my mirror. And here's another nice image showing the powder, the minocycline microspheres, and then as you're pulling out of the pocket, you are continuously releasing all the way until you come out of the pocket. So what is it indicated for? Scaling and root planing, which has not been successful. So you see the patient, you do your four quadrants of scaling and root planing. They come back, reevaluation 4 to 6 weeks, still 5 millimeters. There's still some bleeding. Maybe those areas could be treated with some Arrestin. Contraindications, any history of allergy to the drug, and it's in the tetracycline family, which means that if someone is allergic to tetracycline, they will also be allergic to minocycline. Another contraindication is someone that has a history of oral candidiasis or thrush. You don't want to be introducing something that might be killing off some of the good bugs in their oral cavity. They may end up with a yeast infection. Only someone that has a history of thrush might that happen to. Some other considerations. Does the patient need to be premedicated before you can insert this? Also, pregnancy, nursing mothers, you don't want to introduce tetracycline into someone that is expecting a baby or even a child up to about 10 years old because it can affect their teeth. It is also contraindicated in nursing mothers because it is excreted through the breast milk. And also, it's not used to treat abscesses. What are you going to teach the patient before they leave? So you don't just bounce them out of your chair and say, good luck. What are you going to do? You're going to tell them where it is. You're going to tell them the amount of time necessary for it to reach its effectiveness. You're going to notify the office. Tell them, notify the office if pain or swelling appears, or if you see like a lot of yellow, like just exuding out that night, this, like the yellow sticky stuff, they might want to come back in and have it replaced. Now, it's interesting, like pain, swelling, our pain perception or our reaction to pain is different. Like they're going to feel some fullness, is how I would describe it, where you've placed it. But it shouldn't be painful and it shouldn't be swelling. Or if they have anything like trouble breathing, they should call. But it's not going to feel like nothing, but maybe like a sense of fullness in that area, and you'll show them where it is. The other thing you want to tell them is don't be chewing on hard, chewy, crusty foods, taffy, things like that. Don't brush the teeth, the treated teeth for 12 hours. Don't use anything interproximally, floss, proxy brushes for about 10 days. And don't have them stick their fingers in the area trying to fool around with it or have their tongue touch it. Paradex is optional, which is a prescription mouthwash of chlorhexidine.